Okay, so the CDC is backing off of Johnson & Johnson again. There was an emergency use authorization which was then taken away, which was then given back, and now a statement saying that the preference should probably be to get Moderna or Pfizer over the Johnson & Johnson if you have options. Let's talk through the timeline of what that meant. Let's talk through the statistics of who is most at risk and how at risk they are for the particular issue of concern, which is this type of blood clot. And let's talk about why someone might actually still want to get the Johnson & Johnson. It's going to be a lot of nerdy stuff. There will be some timestamps below if only some of that interests you. Let's get into it. The slides that I'm going to be showing are actually slides that I downloaded straight off the CDC website. So if you remember back to February 2021, that was a scary time. Johnson & Johnson just got their emergency use authorization, which is great because then now we have a third option. At that point, not all adults actually had authorization to get it. There were waiting issues and queues, and people were checking which wave they were and when they'd be authorized to get it. So to have more options when there were tons of adults who needed to have access to a vaccine was wonderful. And that was great because Johnson & Johnson gave us that. Then April 13th came around. That was a big day because of reports of a new clot issue, blood clot issue that had come up. The CDC decided we were going to put a pause. They didn't call it a permanent end, they called it a pause for issuing the Johnson & Johnson vaccine and not allow it to be given anymore. And then 10 days later, they stopped the pause. And they stopped the pause because they felt that the risk that had been going on was not as bad as the risk of people not getting the COVID vaccine at all. And at that point, the numbers that they had were a little bit lower than what we've got now, so they restarted that just 10 days later. That data comes in through VAERS. I'll go ahead and put the slide up here and let everyone get that. That is my own commercial for this. I think that the COVID vaccines so far have been proven pretty reasonable at reducing risk of death. Part of the reason that I feel confident about that is because we have an open access system to report symptoms and problems, and those can then get looked into, and then if we need to make new notices, give new disclosures, if we need to stop certain vaccines from being given out, we can do so. I think this whole story is an incidence of VAERS actually doing its job, which is to notify us if we start noticing patterns. So anyone can report symptoms that they feel are timed or potentially connected to a vaccine, and then that allows everyone to go and start looking into it, allows the CDC to investigate. That is an important thing, that if you've been having symptoms or if you know someone who does, that it gets reported so that people can look into it, because you may be able to benefit other people. Good, open, transparent information is good for everybody. And what that information so far is showing is that the majority of the risk for this issue tends to be kind of concentrated toward women under 50. When the first pause happened, it was drastically leaning towards women under 50 who were at the most at risk for having this issue. Now it seems to be a little more spread, but still women under 50, although now there's a little more data. Before it was split to women under 50, women over 50, and then men under 50, men over 50. Now they've split it up by age ranges a little bit more. Now we are dealing with women under 50 are the most of it. But let's kind of break through a little bit more of the demographics of some of the risk factors, because initially I had some assumptions that I think have so far proven to be wrong. I do think it's important to mention that all of the instances of this clotting issue have been found after the first dose of the Johnson & Johnson, and none of them have been tied with the booster yet. As the Johnson & Johnson was only recently given an emergency use authorization for boosters, I think that it is possible that the small amount relatively to the first dose that's been given out is part of the reason for that, but time will tell. But so far, only with the first dose have we had these problems reported. It's probably not incredibly shocking to everyone who has seen COVID cause more problems in folks who have certain risk factors like obesity, hypertension, and diabetes. Those are kind of the big three, other than lung problems, that get mentioned as being an increase of a physical risk factor for bad outcomes with COVID. But those who, when you look through folks who've had this clotting issue with the Johnson & Johnson vaccine associated with it, obesity, hypertension, and diabetes are also significant risk factors there. So that is a concerning thing. Now I'm going to move to the part where a physician in America admits that they got something wrong. When I looked at the first data for the pause, and I did a whole video walking through that, when I looked at that, I really thought that part of the reason women under 50 were more likely to have clotting issues is because women under 50 are disproportionately more likely to be using hormonal birth control, which is known to have a potential increase in clotting risk. And I said, wow, I bet there's a chance that there's something going on there, and maybe we'll know more later, but I bet that's probably it. Interestingly enough, that was a pretty low risk factor, and only 6% of those who had this clotting issue were actually on hormonal birth control. So a swing and a miss for me on that one. I did not catch that right. I would not have predicted that obesity was such a high impact on the likelihood of this happening, but apparently that is the case. Now, this part of it is actually pretty concerning to me when I look through, hey, how do we try and predict if someone takes the Johnson & Johnson vaccine, the odds that they'll have this? 40% of the people who had this clotting issue had none of these above risk factors. And that is confusing to me because that means it's harder to predict, and that means that people who might otherwise want to try and assume that their risks were very, very low are also significantly represented in the group of people who've had this issue. And that is a problem, right? Because normally you would like to be able to find, like, if you know there's a risk factor for something, you'd like to be able to identify a group of people who don't really have that risk. And you can't necessarily rule out, well, if you don't have obesity, you don't have hypertension, you don't have diabetes, then you're good to go. Because 40%, almost 39, 40% of the people who had this issue had none of those risk factors at all. So let's break down then, if we can't necessarily predict by physical conditions, let's break down by demographics. We're talking age and sex at this point. Let's break down who's the most at risk. Now, since the Johnson & Johnson has had their emergency use authorization reinstated and started to come back, I have personally been telling my patients when I talk to them that if you are a woman under 50 and therefore you're in America where I happen to practice, you probably have options to go get the Pfizer or Moderna, and I suggested to them they should consider getting those instead because the risk for women under 50 was listed as like 13 out of a million at that point for women under 50. And while 13 out of a million is still a very, very low risk, we have to acknowledge that. That's still a very, very low risk. It is still 13 more than zero. And that is the statement that I have been giving to my patients since the Johnson & Johnson vaccine was reinstated as an option. I have also been telling people that statistically at that point, older men didn't seem to have that much of a risk. Now, some of that stuff still seems to be true, and we'll put the numbers up here. So women under 50 are still statistically much more likely to have problems with this than everybody else. It does seem like it's not necessarily the younger women as much, 18 to 29, but once you hit 30 to 50, that seems to be the unfortunate sweet spot of folks who have a higher risk. And you can see that there. That is problematic, right? Because that's a significant portion of a population. Again, I probably beforehand was thinking that this might be tied to hormonal birth control use, and potentially that was a correlation factor there, or maybe a contributing cause. But when you look back at those numbers, like we talked earlier, I was wrong on that altogether because only 6% of those folks who had this issue were also on hormonal birth. Now, I want to point something else out here that's pretty specific. When you look down at the bottom of the slide, you're going to see the overall reporting risk per million Janssen doses. And this is where statistics can be true and also inaccurate. So it's important that if you watch someone talk about the news, you might hear someone say, hey, there's a 3.8% or 3.8 out of a million risk that you're going to get a blood clot if you take a Johnson & Johnson vaccine. And that might be true if you were the average of all Americans, right? But the issue is you are not, and you have to look at your sex and your age range to determine where you are at. And the trouble is some folks will look at these reporting rates and they'll try to add them up. And that's not true because these are split things. These are not cumulative. So if you look at those columns, this is within these groups, if you take the average risk of 3.8 per million, and then you say, okay, well, let's really, really zoom in a little bit. Let's not do quite such a bird's eye view. Let's zoom in. Let's look only at women 40 to 49. If you're a woman 40 to 49, you do not have a risk of 3.8 per million. Your risk is 9 per million. So it's important to look at that. And if you're a 70-year-old man, your risk of getting a blood clot so far, per reported data so far, is 0. Like it's not a problem so far that has been reported to you. So you can't just look at the total population average and say, this is my risk, because you are an individual person. You have much more unique characteristics than just the average of the entire population. So pay attention to statistics when you look at them, because a number can be accurate and not necessarily totally relevant to you. And speaking of accurate and maybe not relevant to exactly what you're saying, it is important to notice a couple limitations of the data, and I want to applaud the CDC for being pretty upfront about this. There's a couple things here. So I am a fan of VAERS. I think it is good to have open, transparent data. I have also been a critic of those who have said, well, VAERS had 8 million reports of this, so there's 8 million cases of this. That is not necessarily accurate, because anybody can click on VAERS and just start saying things. And whatever you say ends up in the reported data, because we are trying to keep that system transparent. So it is possible in some things that you can have an over-reporting, or you can have people trying to assume that a report implies proof, which is not necessarily true, right? The other thing, and the other side of that, is because VAERS requires someone to think, hey, this might be connected to the vaccine, and then know that VAERS exists, and then take the energy to go and report it to VAERS. It is very, very possible, because VAERS is a passive system, to have under-reporting of particular things. They are very clear in this data reporting here that they did not go through every medical record in the country, find every single case of this particular type of blood clot, and then go through each of those people's medical records and see if they had been given a Johnson & Johnson vaccine recently. That is not what they did. They looked through VAERS to try and find, and people who individually called to the CDC and report things, they looked through reports that came to them, tried to investigate them and see if they were potentially relevant. So these numbers come with a bit of an asterisk on them, because there is a possibility of both under and over reporting based on what is going on. Now, the next part is a bit of a problem for me. So I think when I look at this, I go, oh, well, we know we have more risk here. We know, at least in America, we have now an abundant supply of vaccines, to the point where anybody who really wants one can go get one. That is just the way we are set up now. For a long time, that was not the case. I remember the days when there were Facebook posts of people begging and trying to find an appointment slot, and people were driving 2 hours to go get a vaccine. That is not really the case in most cities anymore. So why would the Johnson & Johnson vaccine still be available for emergency use if we already have a fully approved version by Pfizer, an emergency use for Moderna, and the CDC is openly saying, hey, if you've got options, you should probably go consider these other two? Why is Johnson & Johnson still on the table? That is an interesting question to me, and I'm not sure that I understand all of it, but I'm going to try and talk through some of the reasons, right, that at least I have heard. One is that there are some people who are just very uncomfortable, and I don't think that statistically this makes sense, but they just have a discomfort with the notion of an mRNA vaccine, and they like the idea of a more traditional vector type delivery system for vaccination, and they just want the Johnson & Johnson. And that's fine. So that does exist as an option for some people who that's where they're at. I think that traditionally when we first came out, it was, hey, we just need to have other options because there's not enough for everybody. That reason is basically gone at this point here in the United States. So I want to bring up a concern that I have about one particular thing. So, and I'll put up a slide here of a CNN news article. Plus, and I'm going to actually quote them here, plus, the Janssen vaccine is often the only shot available to prison populations, the homeless, and other high-risk groups. Now, I have some problems with this. I know that when Johnson & Johnson first came out, I was actually kind of excited about it for one of the options of, I worked with a number of folks who were homeless at the time, and someone who was homeless and maybe less capable of getting back at a particular time to get their second dose, I felt if I could give them one dose and get them full coverage, and that's what we believed at the time, that was a win, right? The other thing was that the Pfizer vaccine required very specific cooling that we didn't have in all places, and so having another supply option that would allow us to go into more rural areas that didn't have the super cooling would be great. So folks who are far more rural. I now work in a rural setting, and so that's great because my current hospital only has Moderna. So I think that option was good at the time. And I think there are still some potential benefits to the notion of something that technically gives a decent amount of coverage with one dose as opposed to requiring 2 or 3 series or something like that. I have a lot of concerns with saying that the prison population at this point should only be getting Janssen & Janssen. At the risk of getting political, when we put someone in prison, we have removed their ability to go and shop for their own health care and take care of themselves. And we should absolutely be able to provide Moderna or Pfizer to a prison population. The cost difference is not significant. The logistical difference between Moderna and Johnson is not that different. It's not like a homeless population where you wonder if they're going to come back. Frankly, if you're in prison, you're there. You're going to be there to get your next dose, likely. I don't understand the notion that, or any claim that Johnson & Johnson has to be there so we can take care of the prison population. If we are viewing and openly saying for everybody else that it is a potentially inferior vaccine with higher risk, which it seems to be like that's potentially what the CDC is saying right now in terms of risk versus reward benefit, that ratio there. Why would we assume that it's okay to just make that for the prison people? And I don't have an understanding for that. I don't necessarily like it for the homeless population in the sense that I think they should have access to the same stuff, and I would generally offer the Moderna. But if the concern is, well, you're not going to be able to get back here reliably, then maybe you go with the Johnson & Johnson there. But for folks who logistically are always going to be in the same place for the duration of their series, I don't see any reason why the prison population would be relegated to getting the Johnson & Johnson on this. So that's a concern I have. I just wanted to get that out there. So this is going to be getting people asking a lot of questions, and I'm sure that because the CDC has changed directions a couple of times, there are going to be people who are going to doubt the effectiveness of this process. And I want to be clear that I think this is a sign that the process is potentially actually effective, because we started with something that we thought was good, and when we got more data, we said, hold up, we need to take a look at it. When it appeared that the risk-benefit discussion was actually in the favor of moving forward with offering it, and whether you agreed with that decision or not, that was the decision that was made. They looked at it, they said, hey, we think this actually makes sense, so they started it back up again. They kept looking at it, they kept going through the reports, they kept surveillance of what was happening, and when they felt that the numbers didn't add up to keep going anymore, they had to admit it. Even though there was a little bit of egg on everybody's face, they had to admit it and say, hey, this doesn't really work, we need to pause, we need to like change our recommendations a little bit. I think that is a decent reflection of a system that is trying to work. So I don't think this is an abject failure in the system, because it is important that we keep looking at things, and when we find new data, be able to react. We can't assume that a change in direction means we always failed. I think it is important to be honest, and when you have new information, move forward. So I think that the scientific process is actually potentially working right there. The other thing is, obviously, I have had some criticism about some of the risk factors of the Johnson & Johnson compared to the other vaccines moving forward. But I want to be super clear at this point, so far, with all the data we have, I still believe that vaccination gives mortality benefit, helps you not die from getting a COVID infection. I think most people, almost everyone in this country, would probably benefit from that based off the statistics that we're seeing. That's certainly the data coming out from the CDC so far. So if you're not vaccinated, please consider it. Please talk to your physician if you think you have relevant risk factors, and try the best you can to be safe out there, because this is a pandemic that is still with us, and it might be part of our life for a long time. So do the best you can to get by and find a way through. Thanks. Have a nice day, y'all.